So thank you so much for having me. I was really honored to come and be able to speak with you guys virtually. And I'm really sorry that I wasn't able to be there in person. I really considered it. I was on labor and delivery every other day this week, so I couldn't make the timing work in terms of travel. But I've been working with Jennifer for a few years now. And I was very excited to be able to talk to you all about evidence-based labor induction and the work that we've been doing towards standardization. I have no financial disclosures. I have funding from the NICHD in terms of a K that just ended, an R01 and a U24. Today, what I'm going to talk to you about is the significance of talking about induction, which I think for any of you that do any clinical work on labor and delivery probably know just how vast this issue is for all of us managing pregnant patients these days. We're going to talk about how ARRIVE and elective induction sort of ties into that significance. We're going to talk about what's evidence-based in this space, and there's so much data out there around evidence for individual components of labor induction, such as cervical ripening methods, outpatient ripening, amniotomy, cervical exams. And then we're going to talk about putting that all together and standardization of induction management with a focus on racial disparities. I am a maternal fetal medicine physician at Penn, and so I'm going to be talking to you about the implementation work we did at Penn, which was my K23 project, which was a hybrid trial looking at both effectiveness of standardizing labor induction as well as implementation outcomes. Things like how do clinicians feel about this? How do patients feel about it? And talk to you about some of our preliminary data and ongoing work in this space, although all of that has not yet been published or released. A caveat is that there's lots of special situations around induction that we're not really going to be focusing on today. We're going to be talking about primarily induction with intact membranes and an unfavorable cervix, those kind of both medically indicated and elective inductions we're seeing most commonly. So we're not going to be talking about things like people being induced after having had a prior C-section. We're not going to be talking about prom inductions, and we're not going to be talking about those inductions that happen after fetal demises. All of those are sort of special situations that require some special management. So let's talk about significance. So we know that the rate of induction varies significantly by where we practice. Overall, the rate of induction is only about 10% worldwide, but that's still more than 13 million inductions each year. Rates are different by continent, but in the US, over the last few years, the rate of induction, which went from about 10% in 1990 to in the 20% range in the early 2000s to 31.4% in 2020. That's more than tripled from 1990 to now. A third of our deliveries are all from labor inductions. So this is something that's really important in thinking about how we manage. Why is labor induction rates so different by geography? There's differences in the availability of the medications that we use to induce labor, the facilities that are available for monitoring for induction, healthcare staffing, just culture. Sometimes it's lack of adherence to guidelines or protocols for recommendations for medical inductions of labor. And there's huge variation in terms of the rates of elective induction. So the ARRIVE trial. So here, I wanted to go into this, and Jennifer asked me specifically to kind of focus on this. So I really wanted to kind of go over exactly what the ARRIVE trial says and what it doesn't say, which I think is really critical. So this was a study that was published in 2018 from the MFMU. So this is a research network of many centers across the United States that can do these kind of large scale randomized clinical trials that are kind of incapable of being done at a single center. This was about 6,100 low-risk nulliparous women only at 41 different hospitals in the US. And they were between 38 and 0 and 38 and 6 is when they could be randomized. And they were randomized to either be induced between 39 and 0 and 39 and 4, or just be expectantly managed. And what did that mean for the expectant management group? They were expected to forego elective delivery before 40 and 5 and to be delivered no later than 42 and 2. That doesn't mean they couldn't have gone in spontaneous labor at any point or ended up with a medical indication for delivery earlier, but they couldn't undergo elective induction until after 40 and 5. The primary outcome, which is often forgotten, is a composite of adverse perinatal events, which really has to do with neonatal morbidity and mortality. And then the major secondary outcome was cesarean. So when they looked at these two groups, essentially what they saw is that the majority of patients adhered to the protocol that they were assigned. Women in the induction group did deliver significantly earlier than those in the expectant management group, on average at 39 and 3 compared to 40 and 0. But it wasn't 40 and 6, it wasn't 41 and 0, it was 40 and 0. So there were lots of times that the patients ended up with medical indications for delivery or ended up coming in spontaneous labor. The primary perinatal outcome was not quite statistically significant between the two groups. So actually the ARRIVE trial is primarily a negative trial, comparing 4.4% in the induction group and 5.4% in the expectant management group. There was, in terms of looking at the components of that primary outcome, a decreased need for respiratory support in the induction group. And then when they looked at that frequency of C-section, which is what we talk about a lot around ARRIVE, it was significantly lower in that induction group at 18.6% versus 22.2%. It was a 16% reduction. And they showed a significant reduction in hypertensive disorders of pregnancy. So their conclusions were that induction at 39 weeks in low-risk nulliparous women results in a lower frequency of C-section without a statistically significant change in composite adverse perinatal outcomes. There's so much controversy. Why does everyone go crazy over this? Well, I think that the problem is that people misinterpret the conclusions. They say that the conclusions are that now we can tell people who need an induction that it doesn't increase their C-section rate. We already knew that induction doesn't necessarily increase the C-section rate, but the study really has nothing to do with anyone who needs an induction. This is really a study of people who didn't otherwise need an induction. So what happens to comparing that same person who decides to get induced in the 39th week versus awaiting to see what happens? When a person arrives in spontaneous labor, clearly their C-section rate is lower than the same person getting induced on that same day. But the point is that some of those patients won't just arrive in spontaneous labor. We also know that this happened in academic centers, and we don't know how elective 39-week inductions play out in community settings or in models that are very different from the types of centers that were done here. And a lot of that has to do with standardized practices, which we're going to talk about more. And then the average gestational age of delivery only differed by 4 days. And so, the question of how that explained all these outcomes is really interesting. So the bottom line is that ACOG and SMFM have a statement out there that it's reasonable for OB care providers to offer induction of labor to low-risk women as long as they meet certain criteria. But I think we still really need to understand how this all plays out in the real world and what this really means for our patients as we move ahead, and how those results are being extrapolated to populations that truly were not included in this study. So we know that this is kind of underlying some of that significance of why induction matters so much. That if we want the outcomes of the ARRIVE trial to reflect what we see in the real world every day and all the different models of patients that we take care of, then we also need to be able to take into account how we practice labor induction and really making sure that standardization is part of those practices. So what I will say is that, anyone who does end up requiring induction is at increased risk of a C-section, of choreo, postpartum hemorrhage, of decreased birth satisfaction. So it's really important to target induction from so many different angles. All right, I'm going to move on to the evidence for specific components. So we'll start by talking about cervical ripening. So for those of you who are not as clinical, this is the process that needs to start before we truly think about labor beginning. This is the process of the cervix starting to soften, thin, and very slightly open up, which happens in a lot of actual physiologic changes at the cervical level. There's collagen breakdown that needs to happen and rearrangement of the cervical tissue. There's changes in glycosaminoglycans, increased production of cytokines, white blood cells infiltrate the cervix. Lots of stuff needs to happen at a biological level in the cervix before it's really ready to fully go into labor. So there's lots of ways that we can do cervical ripening. The general categories of things are mechanical ripening. Those are things like intracervical balloons, membrane sweeping, laminaria, and then pharmacologic stuff like prostaglandins and oxytocin, and we can use them together. So one of the things that we talk about in terms of cervical ripening is something called the Bishop score. It's a really common term that's used. And actually, it's one of my favorite things because it was published by a single physician, an Edward Bishop, back in the 60s, who practiced here at the same hospital that I work at, in Pennsylvania Hospital, the first hospital in the country. But what he published is essentially a 3-page editorial. It's not really what we think of as a really rigorous research study. He spends the first 2 pages just describing criteria he feels like would be necessary for induction. Multiparity, greater than 36 weeks, vertex, low risk, quote, permission of the patient, which I hope we have for anything that we do. And then he states that he made a scoring system that in his experience, a score greater than 8 would result in no failures of induction and an average labor of less than 4 hours. And the score, if you've seen it before, encompasses dilation, effacement, station, consistency, and position. He has one graph of actual data. Each dot is one of 500 women that met his criteria for an elective induction, but instead he let go into spontaneous labor. And their Bishop score is down there on the x-axis, days until spontaneous labor on the y. And this is it. And yet this is the same exact scoring system that we use today to decide whether or not someone needs cervical ripening before they start a more intensive induction. So it's really interesting that that is where that came from. There have been Cochrane reviews since then that do show that if you just use oxytocin alone, so that's a medication that's going to make contractions stronger and more frequent, when the Bishop score is less than 6, then you're less likely to succeed. So you do need some amount of cervical ripening in those places. And so that's where that piece of so many induction protocols come from, which is that you don't want to go straight to oxytocin in patients who have, quote, an unfavorable cervix. That's usually defined as that Bishop score less than 6. Based on these kind of Cochrane reviews. And so that's why where and when that cervical ripening becomes necessary. So talking about the specific methods, let's talk about intracervical balloon catheters. So this is a standard Foley balloon that you're seeing there. It's often used in the urethra to actually be placed in the bladder, but it can be used inside the cervix. It works through direct pressure, and that dilation and release of prostaglandins causes continued stromal breakdown and an increased responsiveness to oxytocin. We know that when compared to oxytocin alone in an unfavorable cervix, it's going to decrease the risk of C-section, just like all that other stuff we talked about in regards to Bishop score. The cervix needs to be ripened in those cases. When you compare it to prostaglandins, like a medical management alone, there is some differences. There's a lower rate of tachysystole, meaning too many contractions from the Foley alone, and a lower rate of causing fetal heart rate abnormalities, without a difference in C-section rate overall. There's no increased infectious risk with using this balloon when you have membranes that are intact, which is different than when they're ruptured. And it's most likely safest in settings without fetal monitoring. And we're going to talk about it for outpatient cervical ripening as well. It's stable at room temperature, and it's cheap if you're using a standard Foley balloon. When we think about Foley balloons for cervical ripening, there's a couple of different kinds. That one that I showed you is a single balloon catheter. That's your standard Foley. There also exists double balloon catheters out there. One of the brand names for it is called a Cook catheter. Studies have compared these things. So for example, here, a study of nulliparous women with unfavorable cervices being induced at term, they compared double balloon catheters, single balloon catheters, and a prostaglandin gel. No difference in C-section across those three groups, but the induction to delivery time was longest in that double balloon group, and patients who had the single balloon catheter had significantly less pain than in the double balloon group. And so sort of the bottom line there is that double balloon catheters are, one, more costly because they're a brand name device. They're going to increase your time to delivery and are associated with increased pain. It doesn't mean they don't ever have uses, but it is something that, in general, the evidence supports using a single balloon catheter for cervical ripening. When we think about specific uses of the Foley, there's lots of controversy around volume and placement, but these are things that we tried to think about in terms of standardizing how we all practice. The balloon can be filled anywhere from 30 cc's to 80 cc's of water, can be taped to the thigh or not. So thinking about these things, there's been meta-analysis comparing 30 versus 60 cc's. We know that the more you fill it to, the more likely you're to achieve vaginal delivery within 12 hours compared to if you used 30 cc's. No differences in delivery within 24 hours, C-section rates, labor complications, neonatal outcomes. Even more than 60 cc's up to 80 has been used in some studies with even higher dilation and shorter time to delivery. And so really the data does support increased volume of Foley balloon inflation. The problem is that the package insert tells you not to do that. And so sometimes this becomes an issue in terms of working with your individual site's administration and leadership to talk about the data that supports this to argue for using increased volume. I'll stop here and also say one thing, which is a lot of the data that we're talking about today is really showing evidence for things that decrease the time to delivery, but don't necessarily impact other outcomes. However, what I will say is that we have data that time to delivery is actually one of the single most important things to patients, second only to the way that they end up delivering. Vaginal birth tends to be people's most important priority, and then second to that is how long their induction takes when they're undergoing induction. And so this is really a patient-centered outcome, and I really like to frame it that way in terms of decreasing time to delivery, even if it doesn't decrease other complications or change mode of delivery. We also looked at how that Foley balloon should be placed. There's data around comparing digital to speculum placements, and it's really non-inferior. And so however people want to place the Foley seems like a reasonable way to go. I'll talk briefly about laminaria and dilapan because it's not something that we use in clinical practice. There are a couple types of cervical osmotic dilators that can be placed in the cervical canal. They actually absorb fluids from surrounding tissues and progressively increase their diameter to achieve cervical ripening. But essentially, some of these that are used out in clinical practice, the only one is that Dilapan S. And there are studies showing it to be safe and effective. But when you compare it to Foley balloons, essentially they are the same in terms of their effectiveness, and Foley balloons are infinitely cheaper. In general, we don't use laminaria because of risk of infection, but Dilapan is a reasonable alternative if you don't have any access to other mechanical methods. Again, cost being sort of the primary reason one might pick a Foley. Thinking about now onto the medical management of cervical ripening, misoprostol is a prostaglandin E1. There are many different dosing regimens and routes of administration. The most common and safest are vaginal or oral. Doses can range from 25 to 50 and Q2 to 6. Lower doses are going to stimulate the uterus less concerningly and cause less fetal heart rate decelerations. But when you use the vaginal route, dosing intervals are more commonly Q3 to 6. Oral dosing is more like Q2 to 4. So what's really important here is that it doesn't really matter which one of those things that you use, as long as you're using it at sort of an appropriate interval and an appropriate dose to move things ahead. There are no large studies evaluating the safety and efficacy of buccal or sublingual meso, so we don't recommend using those in continuing pregnancies. There are other types of prostaglandins available. Dinoprostone is prostaglandin E2. It can be used as Prepidil, or Cervidil is kind of the more common one that I've seen. It can be placed vaginally for 12 hours. Compared to Prepidil, with Cervidil, there's been higher rates of vaginal delivery, no difference in C-section. They're approved by the FDA. But again, when you're thinking about comparing these E2s to the E1, misoprostol has a shorter time to delivery and is much cheaper, 25 cents as compared to $200. So using some of these things seems less important. So I'm going to talk a little bit about outpatient induction, because I think that's another piece of thinking about when you're remodeling induction at your site, how you can kind of optimize induction for your patients. Prior Cochrane reviews have shown that it seems feasible to do outpatient induction. Important adverse events seem rare, but there's no strong evidence that there's any positive or negative impact on maternal or neonatal health. What I will say in terms of thinking about specific studies that have been done is that there is data around patient satisfaction and patient-centered outcomes when you think about outpatient induction. There is increased satisfaction with outpatient cervical ripening over inpatient, decreased anxiety. Most women don't worry about making it back to the hospital and are willing to accept more trips to the hospital in order to have outpatient cervical ripening. There's been some comparative RCTs looking at cervical ripening with outpatient Foley that have been small in the past that tell you that essentially the cesarean delivery rates are not significantly different in this small sample, but there is a hint that possibly C-section rates can be lower with outpatient cervical ripening. There's other sort of RCTs that have gone on showing less time in the hospital, lower failed induction rates, both looking at both nulliparous and multiparous patients. There's been more notable outcomes for nulliparous patients as compared to showing differences for multiparous patients who likely just have shorter labor in the first place. So the bottom line of all this is that there is some data out there to support shorter times and increase patient satisfaction. And then there's some hints around possible reductions in cesarean delivery. And at the end of this talk, we'll just mention some ongoing work related to outpatient induction that is hoping to prove a decrease in cesarean delivery rate associated with outpatient Foley induction. And this, importantly, is just speaking about outpatient Foley alone, so not using any other additional form of cervical ripening like prostaglandins in the space. Next, I'm going to talk about combination methods, which I think a lot of people are really trying to put into their standardized induction protocols. This trial, I was a resident at the time at Penn and was able to enroll patients in the study and be a part of their labors. There was about 490 women who were in the study. These were full-term singleton gestations, undergoing labor induction with intact membranes and an unfavorable cervix. And they were randomized to one of 4 induction methods to start. So that misoprostol alone, a Foley alone, doing a misoprostol and a Foley at the same time, and doing Foley and Pitocin at the same time. And these were all inpatient inductions. The primary outcome here, again, was time to delivery. And when you compared all those induction method groups, combination methods actually achieved a faster time to delivery than any single agent method, by about 4 hours, especially when you looked at meso and Foley. And when you censored for C-section and adjusted for parity, those women who received meso and Foley at the same time were almost twice as likely to deliver before women who just got misoprostol alone or Foley alone, and Foley plus PIT wasn't significantly different. So that's where we have the data that sort of supports that meso plus Foley has twice the chance of delivering before either single agent method without having any sort of negative impact. And that may have an important effect, again, on patient satisfaction, on patient-centered outcomes around length of labor. There's also been a recent meta-analysis in this space demonstrating a 4-hour shorter time to delivery and lower rates of NICU admission, meconium, and tachysystole when combination methods were used. And so this is where a lot of the data around the benefit of doing meso and Foley together comes into play. All right. I'm going to move on from cervical ripening to amniotomy and sort of the data we have around that. This is one of the more controversial pieces of oftentimes what these standardized protocols include. So amniotomy is the artificial breaking of someone's water. So there's been some trials looking at this, certainly, and any of you who go to the Society for Maternal Fetal Medicine conference or sort of read those abstracts, you'll see that someone does a study around this almost every year. Some of the key trials are this McCone study, which is from 2012. Of 585 nulliparous term singletons undergoing induction, randomized to either early amniotomy, meaning they were less than or equal to 4 centimeters, or standard of care. They were more than 4 centimeters, but otherwise left up to the provider. And in the early amniotomy group, there was shorter time to delivery by more than 2 hours and more deliveries in 24 hours, with no difference in mode of delivery or in chorioamnionitis. So I think there is good data to support, in general, during an induction and early amniotomy. But should it happen even earlier than 4 centimeters? That's less clear, as soon as that Foley's out or as soon as the cervix is ripe. This one study looking at 168 term inductions were randomized to amniotomy as soon as the Foley balloon expelled, regardless of how dilated they were, versus starting oxytocin first and then doing amniotomy once there were regular contractions or more dilation occurred. And in this study, there was a higher C-section rate in the early amniotomy group with no difference in time to delivery. A kind of combination systematic review study put those 2 studies and 2 more together and showed that when looking at early amniotomy, there was a similar risk of C-section compared with controls, but overall a shorter time from induction to delivery by about 5 hours in the early amniotomy group, with no other difference in maternal or perinatal outcomes. So that piece kind of went into our standardized induction protocol and is often included in a lot of standardized processes around induction. Next, thinking about the frequency of exams. This is one of the pieces that has less data behind it, but is one of those things that, again, we decided to include based on the data in our induction protocol. So this is a 2019 study where 200 women were randomized either to Q4-hour exams in late labor during induction, with the goal of breaking someone's water as soon as it was feasible, or only if indicated exams. The patients are called out for an exam. And when patients had those Q4-hour exams, there was a faster time to delivery, again by about 7 hours, with no difference in mode of delivery or infection. Another study did a randomized trial of 100 nulliparous women who came in spontaneous labor, which is different than our induction patients. And these patients were randomized to vaginal exams every 2 hours versus every 4 hours. No difference here at all in duration of labor, mode of delivery, maternal or neonatal morbidity. And so some observational studies do associate more exams with decreased satisfaction. I think it all depends on the context of which you are taking care of the patient, whether there's beneficial outcomes. And in induction, it does seem that regular checks in latent labor are able to move the labor ahead a little bit farther without negative impacts. But it's always important to take into account the patient satisfaction piece. All right, so that's everything around, we've covered significance, and then we've talked about the evidence. I have a lot of individual pieces of induction components. What I will say is that there's probably a million more studies that I didn't mention there around individual components of labor induction. But that was just kind of an overview of some of the key points that we put together to create our standardized induction protocol. There are lots of different standardized induction protocols out there that people have started to use since I've been doing this work or have talked to me about what they're going to do at their site. And so, I think the hope is that you take your site and kind of turn that data that you see into a protocol that's going to work for you. So I'm going to bring this to racial and ethnic disparities for a second, which is, I think that everyone has seen this slide or some version of this slide who works in this space often in the last few years, which is great, which is that we know mortality specifically is significantly increased for our patients of color. Also, morbidity and significant maternal morbidity is also associated for our patients. But what is less talked about and where some of my work focuses is that there are also significant racial disparities in the cesarean delivery rate, with our non-Hispanic Black patients having about a 10% increased risk of C-section as compared to our white patients. And so, outside of obstetrics, we know that protocols of standardized care have been shown to improve outcomes. And outside of OB, care standardization has been shown to reduce racial disparities in certain outcomes. The idea here is that implicit or even explicit biases that are influencing how clinicians act towards patients can be contributing to some of those racially disparate outcomes that we're seeing. Now, the theory behind how standardization of care can impact disparities is that it's going to minimize the variation in practice that can happen across providers, across sites, and for an individual clinician for patients of different races, thereby minimizing that effect that bias can have on outcomes. Really, really importantly, that is a Band-Aid, right? That is not an underlying solution to this problem of racial disparities. It is not solving the issue of systemic bias, implicit and explicit individual biases that are leading to racially disparate outcomes. It is just kind of putting a fast and immediate answer on top of it to minimize practice variation by requiring this kind of standardized care. So how did we think that standardizing care was going to reduce disparities? So in our prior work, this now moving into kind of having reviewed a lot of data from lots of other people across lots of different sites, this is our work. This is a retrospective cohort study that compared women that were enrolled in that same RCT I already told you about, the trial looking at 4 different methods of starting cervical ripening. Those 491 women who were enrolled in that trial, even though they were randomized to start their induction in a different way, all were required to be taken care of in an extremely standardized approach from there on out. Frequency of cervical exams, timing of amniotomy, when to start Pitocin, how to manage active labor, what to do if there was active labor dystocia. So all of those women were compared to another group of women who were being taken care of during the same time period, who declined being a part of that randomized trial, but allowed us to collect data on their inductions. These patients were all managed however their provider felt was necessary. And so essentially we had about 490 women who had a standardized induction protocol to compare to 364 women at the same site being taken care of by the same providers, but just being managed at provider discretion. And when we compared these things overall, the only significant difference that we saw was in neonatal morbidity. There was a significant reduction in the group where people were being managed with the standardized labor induction protocol in both NICU admission by about 60% when adjusted, and in neonatal morbidity by about 70% when adjusted. Really significant differences that we were seeing there. And then when we look specifically around disparities in outcomes, we saw that for neonatal morbidity, there was no significant difference among non-Black women who were in the labor protocol group versus the observed group. But for Black women specifically, there was a significant reduction in neonatal morbidity if you were in the labor protocol group versus the expectant management group, or not expectant management, the standard management group, which is a 70% reduction in neonatal morbidity. And in C-section rate, this is where we saw a difference as well. There was no difference for non-Black women if you were in a standardized labor induction group versus the observed group. But for Black women, there was a significant reduction in C-section rate from about 35% to 26% if you were in the labor protocol group, which is a 35% reduction, and statistically showed a significant reduction in the racial disparity. So we took all of that and used a very similar protocol that we had used in that RCT to try prospectively then to take a look at how implementing a standardized labor induction protocol was going to work at our sites, as well as impact outcomes in a prospective way. So we took all of this. Our first aim was to look at effectiveness. Does standardizing labor induction improve OB outcomes? By reducing care variation, increasing the use of all of these active labor induction management practices that we just talked about to improve overall outcomes. And then secondarily, to look at these racial disparities from pre to post. Does reducing care variation actually minimize the effect of bias and therefore reduce racial disparities in those outcomes? At the same time, and I mentioned this in the beginning, I'm also an implementation scientist, and as is Jennifer, and she'll tell you that there's really no chance of any intervention being successful at a large scale unless you're able to show that it is acceptable to patients and clinicians, that it's going to be adhered to or used in any sort of fidelity. And so looking at that is more challenging in research than it is to simply look at clinical outcomes across a study. And so this is where we take a mixed methods approach, meaning we'd use a lot of qualitative data as well as quantitative data to look at implementation. So the primary implementation outcomes we're looking at in this work were acceptability. Do patients and providers find a standardized induction protocol agreeable, palatable? And we did this through semi-structured interviews with patients, surveys, and interviews with providers. And then fidelity, are we using the protocol correctly? It's a complicated protocol, and I'll show you exactly what it looks like. But how many of those core components were being used before and after? Now, the study design is not very fancy. It was at 2 sites within our Penn system, which are different in terms of their model. One is, a very academic structured system where it's a very closed unit. Residents are taking care of pretty much all the patients, being staffed by the same group of attendings. And then the second site is a much more what someone might refer to as a private-demics kind of place, where there is a lot of different groups of private practice providers who work there. There's a resident group, there's a huge midwifery group, and so a lot of different kinds of care going on there as well. So we compared 2 years pre and post implementation of this protocol, kind of in a stepped approach across these 2 sites. And so it was implemented at October 2020 at site 1 and in January of 2021 at site 2. These, again, just included patients who were term, singleton gestations, undergoing induction with intact membranes, and didn't have a prior C-section. So fit all that same criteria for all the kinds of data that we had to support what should those components be. Now, we chose strategies to get this protocol into place that were mapped specifically to barriers that we had discussed with multidisciplinary groups at these 2 places. This is not to say that this is a simple process. This is to say that we know that choosing to standardize all of these steps of induction is actually a really challenging thing to do, and that people have really varying opinions on what those steps should be. And so we had lots of conversations with multidisciplinary groups before we went ahead with this implementation. And so we chose these strategies, like making sure that we had all the right people at the table, stakeholder and community engagement buy-in into implementing this protocol. We did a lot of training and education because, again, some of these steps were things that people were already doing at some places for some providers, and some of them were not. So that was definitely a part of it. We know that training and education is never enough to get anything to change, but it is usually necessary. And then really importantly, one of the bigger things we heard even before we got this into place was that people were going to forget to do it, or things were going to get busy and they weren't going to be able to do it. And there was going to be these kinds of barriers to using the protocol. And so audit and feedback was something that we felt was a really important strategy to put into place. So we started doing Q3 month unit level reports on the fidelity to the protocol. What components were people using and which ones weren't they? This is just to show you how complex that protocol looks like. And I'm always happy to send this to sites who are interested in implementing something similar. But this, after a long time, and a lot of adaptation and a lot of modification is where we sort of got in terms of these induction protocols. So this is a separate graph for latent labor. We had these done as big posters that were put up all over our labor and delivery unit. And it kind of goes through many of those things we've already talked about, which is, we actually didn't even require the way that people started an induction because that was one of the things we had trouble getting people to commit to. We encouraged use of combination methods, but, certainly we understood that there was going to be situations where people couldn't use combination methods or that was too challenging. We talked about the frequency of cervical exam recommendation in latent labor to move things ahead. And we did recommend early amniotomy as a part of this. And then active labor, this is kind of a confusing one. We tried to make this as simple as we could. And I think this is one of the things that is also challenging about putting an evidence-based protocol together is that, the balance of evidence-based and optionality and simplicity is very difficult to make together. And so this kind of talked about that, active management of active labor as well, and intervening when people weren't making change in active labor to try and help them move ahead more quickly. So this is an example of what one of those audit and feedback reports looked like. So essentially we had split up the protocol into 8 sort of individual and measurable components of the protocol. Things like, moving labor ahead in latent labor, frequency of exams in latent and active labor, early amniotomy, intervening when people weren't making change in active labor, such as placing an ARPQC or starting oxytocin. And we compared them to, the same site months prior. We heard that people didn't want to be compared to other sites. That was something that wasn't going to be appealing to them. They wanted to be compared to themselves over time. And that is, how we sort of designed this dashboard. And so instead of showing like statistical results with each kind of analysis, we were asked to show smiley faces or sad faces or medium faces to get people to be, informed about what they need to change over the next little bit. And we would include in the email sort of advice about how to move those things ahead. So this is our preliminary data in terms of how that protocol impacted things. What I'll say is that, interestingly, over the course of 4 years, right, a 2-year pre and post implementation study, this really highlights some of the downsides of doing a pre and post study design. Even with the fact that, we were going to have a lot of data, be able to control for a lot of trends over time, and we did have a stepped approach to account for in our statistical analysis. Our patients over those 4 years got sicker. They really did. And that has impacted, I think, our ability to show significant differences. Our patients at delivery were older with higher BMIs, higher rates of chronic hypertension, less favorable Bishop scores, as reflected by the need for actually less able to do combined cervical ripening at the beginning of inductions because of all of these combination of things. And so there were actually a lot of variables to sort of account for in our analysis because our patients had changed so much over the course of only 4 years. We looked at the primary outcome, which our goal had been to reduce C-section rate overall for all our patients. There was actually no significant difference in cesarean delivery rate overall. What I will say is that, even in our pre-period, our C-section rate was lower than it had been in prior years. And so there had always, been some amount of work already happening in this space. It's one of those things that, as with Jennifer's work, there's so many multi-component interventions that can go into reducing cesarean delivery, but we were starting at a better place than we thought we were going to. We also had no change in time to delivery, but we did see a significant reduction in composite maternal morbidity over the course of the study period, which when adjusting for those differences was about a 17% reduction. We can't say 100% that's attributed to the implementation of the protocol, but the things that were lower were postpartum hemorrhage and endometritis, things that can be associated with the way that we interact in patients who are undergoing induction. When we looked at fidelity to the protocol, we did see an increase in utilization, statistically significant in 4 of the 8 components, which, is not as much as I was hoping for, just, with the fact that we put all this intensive implementation strategies into it. However, some of the things we were already doing really well, and so maybe there was less room to actually kind of improve upon some of those things. And some of the situations where people had stalled out in active labor were a little bit rarer than we expected. So we weren't able to show differences in some of those things. But we did increase the frequency of exams in latent labor, early amniotomy, and placing an ARPQC when people stalled out in active labor. When we looked at these kind of things in sort of run charts, these are a little bit hard to explain given the whole 2 separate site situation and the stepped approach. But essentially you can see that we did have an increase in the frequency of and compliance to the latent labor exam frequency recommendation, an increase in utilization of our early amniotomy recommendation, and an increase in compliance with utilizing an intrauterine pressure catheter when people weren't making change in active labor, and these run charts help prove that. When we looked at these kind of markers of labor change, we can see that the increase in fidelity to the protocol did increase some of the actions we expected and sort of the other process-related outcomes within labor, meaning that people then used more misoprostals because they were more actively managing latent labor. There was a lower dilation at membrane rupture because of this recommendation around early amniotomy. There was a faster time to membrane rupture. There was an increased maximum oxytocin dose because the pitocin was being started at a more appropriate time and up-titrated more frequently. Increase in ARPQC utilization overall as well. And so, I think that when we looked at individual sites, it's important to remember that context is really important. And we knew that these sites were starting at different places in regards to their baseline utilization of these components, that they were going to end up different places. And so that was one of the things that I think is really important whenever you're taking into account a place that you're going to implement something like this. As you can see that, for example, when we look at the frequency of latent labor exams, site 1 was already doing our recommendation about 55% of the time. But site 2 was only doing it about 15% of the time, so had a really long way to go in terms of improvement. And so thinking about how to tailor these protocols to the individual place and what their barriers might be at that individual site is really important. So that kind of leads us to the conversations that we had with clinicians and thinking about clinician acceptability of standardizing labor induction. So we did this through survey methodologies as well as through interview methodologies. We essentially started with a survey and a validated measure for acceptability, and then used that to pick people who had low scores of acceptability and high scores of acceptability to interview. So we interviewed about 24 total clinicians, about 3 domains across all of this. Acceptability of efforts to standardize labor induction, what are the barriers and facilitators to actually doing this overall, as well as what are the barriers and facilitators to doing the individual components of it, and how do they recommend doing this better. So these are kind of the outcomes of the survey measure. Overall, the score was about 15 out of 20 of acceptability, which is good, not great. And we asked about the acceptability of these individual components. And so you can see that there were pieces that, even less than half of the people, despite the fact that we'd already implemented this protocol, found acceptable. And so this is something that we're still, working on in terms of challenging that frequency of latent labor exams and early amniotomy being some of the most challenging things. And certainly there were some differences by site as well. So like I said, we interviewed 24 people. The average score of the acceptability survey in the low acceptability group was about 12.5 out of 20. And in the high group, everyone had 20 out of 20. And so first we asked about, again, the acceptability of efforts to standardize induction in general. And I would say broadly, people felt really good about the idea of standardizing labor induction. They thought that it was important to both reduce disparities and reduce rates of C-section. And they were enthusiastic about the idea, but they also felt like there was, caveats to that. So the people in the low acceptability group were more likely to add some nuance to this belief, noting that providers also need to be flexible and consider the specific needs of the unique patient in front of them, which is also not unreasonable. I think it's good to standardize labor practices. I think that aim to make sure that everyone's being cared for on the same level and given the same attention is good. I do think there has to be room for specifications to the situation and to the patient. So while it's good to standardize things, I think you have to be open to what happens and what changes with that patient specifically. Then we talked about barriers and facilitators. I think there's so many issues. One of the primary things that any clinician will tell you whenever you're trying to make any change is time, right? Everyone described their floors as busy, high volume, not having sufficient staff to meet all the patient needs in a timely manner. And that demands on their and their peers' time actually impeded their ability to implement the protocol, such as to, go and check the patient when they were due. Other things included clinician resistance, like disagreement about best practices. There were differences in terms of those provider roles and what they disagreed about. And then practical challenges, meaning like the physician or midwife also needed the nurse to be there to do the next step. And they're, getting everyone together to do the check or to do the thing was a little bit challenging. There was also clinician perceived patient resistance, believing that patients were against intervention on principle, and that there were patient preconceptions about those interventions coming into induction. And so that's something that we then explore in the actual patient interviews, which I'll go into. And so then, the final domain of clinician interviews were recommendations for improved implementation. And so, one of the major things was making sure that nursing and resident trainees were educated in our units because of the rotating nature and sort of the high volume of them, so that people who were kind of actively doing the actions were well informed. And that better education of patients on the labor protocol, even before they come in for induction, was really critical. But they need to know about these interventions, what they're for, why, and when they're going to happen on labor and delivery, or when they'll be recommended, so people can come in without having to have, unique individual counseling every time. It kind of delays the process from moving ahead. And then clear communication about what the next steps in the protocol are, why we're planning to do it for that given patient at a time, communicating within the team if, one person who was taking care of the patient is then too busy to go do that step, harnessing other people on the team to help move it ahead. And so, I think task sharing became one of the recommendations as well in order to help move a protocol like this ahead. I'm going to move on to patient interviews. I think it nicely kind of complements the provider interviews that we did. We just did 11 patient interviews who were involved in the labor induction protocol study between November 22 and March 23. Most of our patients were nulliparous and identified as Black, and one of our residents kind of led this piece of the work. And you can kind of see the descriptions of those patients here. So we talked a lot about understanding and general experience with induction, and then the experience with an acceptability of those specific components, understanding that patients might not have had another experience to compare the induction process to. So starting with that understanding, I think in general, these patients had positive sentiments about their induction and had really positive things to say. And the rare negative reflections were around pain and duration of labor. And again, those kind of reflect the same things that we knew are values of patients going into labor induction. When asked specifically about misoprostol, most patients had never heard of meso prior to their induction, but if you recalled, it would soften the cervix and start dilation. And then we asked about their experience with it. And honestly, most people felt like the placement was nothing. I honestly didn't feel anything. And no patients actually described any discomfort with misoprostol after the placement. And they universally felt like, oh yeah, that helped with my induction. When asked about Foley balloons, again, many people had not heard about this prior to their induction. Some had heard about it from family members in prenatal care or from TV or social media. And they were more likely to then be afraid of it, thinking about pain in a foreign body. The experience with placement, though, was primarily felt to be not as painful as expected, but there were a couple people who said, I would never do that again, only if I absolutely had to. But overwhelmingly, people thought it was helpful in moving their induction ahead. Pitocin. So most patients had heard about Pitocin prior to induction and had a range of sentiments. So it's sort of interesting that I think our protocols focus a lot on active management of latent labor, sort of using combined methods, using Foley balloons in that early part of latent labor to move things ahead and reduce time to delivery. And I think that the clinicians had this perception that patients were very against them. And certainly some people are. But I think that the patient perception we received from these interviews was far more positive than the clinicians perceived patients to feel about Foley balloons. On the other hand, I think clinicians felt like Pitocin was not a big deal, and yet patients actually felt more aversion to Pitocin. So there was a lot of ambivalence about it, and then concerns, again, based on information they had mostly gotten from friends or social media related to pain, and a desire to avoid it during the process of their induction. And yet most of these patients were coming in for scheduled inductions of labor from an unfavorable cervix. We know that over 90% of those people are going to need Pitocin throughout their induction, but yet came in with this perception that they were going to or wanted to avoid it. And so this kind of comes back to that outpatient education piece. And so again, the experience with Pitocin focused on pain, back-to-back contractions, wanting an epidural before they start Pitocin, and the belief that, but they did believe that Pitocin helped speed up their labor. Amniotomy, again, this is one of those things that clinicians perceived patients didn't want, but our patient interviews mostly expressed neutrality or positive emotions about amniotomy. So I was actually excited to get my water broke. I knew once my water broke, the process would start to speed up. It seemed like it was going to be a breeze. And a minority had concerns related to pain, but no participants expressed any other concerns related to amniotomy in this work. The experience was unexpectedly painless, warm, or release of pressure, people described. And it was so warm, I just felt like I was peeing on myself. And most stated it helped to speed up the process. Cervical exams is sort of interesting in terms of, again, expectations. Most patients came in with a completely wide variation in what they thought the frequency of exams were going to be, from much less frequent than expected to much more frequent than expected. I thought we'd have one exam and be done. I thought it would be every hour. And then the minority expressed significant discomfort related to exams. Most people thought they were fine. And most described them as pressure. So, I think in summary of all of this kind of patient understanding is that, clinicians have a lot of preconceived notions about what patients feel about induction, when for the most part, I think, the components related to this, they have one, a lack of understanding and education from the outpatient perspective, and are getting a lot of their information not from their providers, but from social media or TV or friends. And that in actuality afterwards, most patients feel like the thing was not as bad as they thought it was going to be. And so, kind of targets that education piece. I briefly just wanted to bring up the fact that we have this ongoing multi-site trial being led by Lisa Levine here at Penn and Allison Cahill as well, around outpatient cervical ripening. Again, it's a randomized trial of outpatient Foley for nulliparous patients for almost every either medically indicated or elective term induction to hopefully show a reduction in C-section rate as well. And for that will be about 2,300. It's going on at UT Austin, Utah, Christiana, and Penn. But in addition, I'm working with them to kind of, again, look at the implementation arm of all of this and sort of understand both patient and provider acceptability and barriers and facilitators to implementing this at sites, so that hopefully we can take strategies from what we learned so that we can better implement across the country. So I've been talking for a long time, so I'm just going to kind of put it all together, and then I'm happy to take questions. I talk fast, I know. So I think kind of this is a long talk that kind of can seem circuitous, but what I'll say is that, the beginning is that induction is highly prevalent. We're all dealing with so many problems related to induction at our sites. It is many patients want or being scheduled for inductions. We're worried about efficiency on our units. We're worried about cost and time and staffing. We're worried about our patient satisfaction related to inductions, and we're worried about our clinical outcomes. What we have is a plethora of supporting evidence around different components of active management of labor induction, different pieces that will do some of those things. Reduce the time to delivery, reduce C-section rate, reduce pain, improve patient satisfaction, and maybe affect disparities in those outcomes. And that when we put all that together, while there are many barriers to standardizing labor induction, and it can seem like an unconquerable challenge, we can make some change in terms of decreasing variation in care, even among different practice models, at least to a degree. And that lessons learned from our own implementation, combining both our quantitative and qualitative data, is that one, I think that you need to include all the stakeholders from the start. Everyone who's possibly going to take care or touch your patient on labor and delivery, as well as people from the outpatient setting who can help you figure out how to do outpatient education so that patients can be ready for the thing that you are recommending on labor and delivery. Also, patient and community engagement. Using a data-driven approach is really important. I think people are really resistant to change when you don't have baseline data to show them to say that these are issues. Education needs to reach everyone, and it needs to be ongoing, because these kinds of processes, again, people are going to come in with a lot of notions about how to take care of patients in the setting of induction. And if you're going to standardize processes, there needs to be recurring education. The conversations need to start in prenatal care. Patients need to hear about these things from their clinicians in an evidence-based approach about what's going to happen on labor and delivery without a lot of myth, right? There's so much myth out there about Foley balloons, about pain, about Pitocin that we can help deal with before patients get to L&D. I think if you're going to try to standardize induction, there are a lot of steps, and it actually takes a lot of focus and work in patients who are undergoing early parts of their induction, who may seem less important than your patient who's having a uterine rupture, your patient's having an infection or a postpartum hemorrhage. And so you need to kind of break down role-based barriers to be able to say we can all work together to actively manage our patients' inductions to help prevent that other stuff from happening. And that communication is really important among members of the team to get any of that done. I could talk about this all day, so I'm sorry about the quickness of it. I'm going to stop there, and I'm happy to take any questions. I can't see the room, or so if anyone wants to come to the mic, or I don't know how that will work.
No, you're in the black hole, but yeah. Chris, now I know we had you muted earlier. Do we have any questions? And I think you can use your microphone on the desk to ask questions. Thank you, Dr. Hamm. That was great and very informative, and gives us a lot of things to consider when we think about inductions and how we manage them and how we educate. So thank you very much. Any questions from anyone in the audience? All right. Someone was asking for your email address. So can we put that? Okay.
I can put that in the chat. Really silly long. They give us these very long.
We had a question of, was the Pitocin administration standardized? Did I get that right?
Yeah, so our recommendation around Pitocin was our protocols allow us to go up to 40 units, started to increase by 2 Q15 minutes with criteria for nursing to come and talk to the provider about whether or not the Pitocin should go up or not. But it was part of our protocol and standardization implementation to, I know that in many places this is already highly in the hands of nursing, but to really empower our nurses to be able to actually meet that, to actually go up every 15 minutes. Unless otherwise contraindicated, and then if they're going to lower it, turn it off, to come and talk to a provider about it, so that at least there can be a multidisciplinary conversation about whether or not that's best for the patient.
All right, thank you.
I have a question about engagement with your providers, staff, and all that with such a change? You know, what do you feel like is your most successful method to try to make this change?
Yeah. I think that one of the things that, both worked and didn't work and we had to, adjust on later on is that you want to get those people who are going to be the most outspoken against something like this engaged in it from the very beginning, right? Like I think that there is, obviously people who feel strongly in different ways about this kind of process and that it can be something that's really controversial. And what you really need to do is not just, target the people who are going to find your thing acceptable and engage them. You have to engage those people who are not going to find your thing acceptable. And so that I think we did a little bit of, and then later on, adapted to the fact that we really needed to talk to those people and figure out how we can make this work as best as possible for them. So that, we were at least not, having those huge dissenting voices throughout the process. If that helps.
I have one more question.
Sure.
So you mentioned the ARRIVE trial and how
Yeah.
it was mainly out of an academic setting. If you were to try to predict how this would go in a community setting, which is, majority of Arkansas, how do you think that the outcome would be?
Yeah, I mean, I think that there has been some attempt at that work. I didn't put any of those studies up on the slides, but to look at sort of the impact at a national level. And some studies have shown, similar overall impacts, and some studies have not. So there's kind of mixed data about the kind of overall impact on the ARRIVE trial in the country as a whole. What I'll say is that I think that it needs to be tailored to that individual place in that, when places don't have 24/7 clinician coverage, or there is a model of like the person's day could end at 5 o'clock, and so you could decide to do the C-section for a failed induction at 12 hours only because your day is ending, and then instead of waiting to 24 hours when that patient might actually progress to have a vaginal delivery, then that higher rate of induction does have the chance of having a negative impact on cesarean delivery rate. And so I think thinking about models of care, timing of those labor inductions, and how all of that can play into your unit is important. The last thing I'll say is that even within our own academic center, we have problems with how ARRIVE is implemented, which is that, we don't necessarily have space for all those 39-week inductions. And so what ends up happening is that some people who want an elective induction don't end up getting induced until after their 40th week, right? So, at 40 and 1, 40 and 2, because of, they were waiting on a wait list to get their elective induction. And we actually have no good data to say that inducing that same patient instead of at 39 and 0, but at 40 and 0 is actually still beneficial for that patient, right? So I think, making sure that if you're going to implement something like this, it's actually to target getting people delivered in that 39 and 0 to 39 and 4 week range, which is what the trial was actually able to show an improvement in, because we don't know that that same impact would happen if you waited a little longer.
Sorry, last question.
No, these are great questions.
Do you know of any sort of standardization with regards to counseling prior to 39 weeks, to try to help with going into labor on their own and initiating some contractions on their own prior to?
Yeah, we don't have any counseling on, ways to augment your own likelihood of going into labor. I think that's a great intervention to develop and study if it doesn't already exist.
Any other questions? Are we good? All right. Thank you, Dr. Hamm,
Thank you
again
for having me.
today and bringing this research to us and explaining your process there at Penn. So we appreciate it.